Good afternoon. Thank you for joining us on today's Facebook Live, Mayo Clinic NeuroChat. My name is Dr. Nick Wetjen. I'm a neurosurgeon, a pediatric neurosurgeon here at the Mayo Clinic, and today we're going to be talking about spina bifida and fetal surgery. We'll be taking questions throughout the broadcast, so make sure to post your questions in the comments section. Joining me today, we're lucky to have Dr. Rodrigo Ruano and Dr. Suresh Kotagal. Dr. Ruano and Dr. Kotagal, thank you for joining me today. Why don't you tell me a little bit about yourself to the audience? I know you pretty well, but we want to let the audience know about you and your area of expertise.
Thank you, Dr. Wetjen, for the introduction. My name is Rodrigo Ruano. I'm the director of the maternal fetal medicine and the fetal center at Mayo Clinic, and I'll be happy to talk about fetal surgeries here, especially about spina bifida.
Thank you.
Thank you, Nick. Thanks for inviting me to speak today and join you. My name is Suresh Kotagal, and I'm a child neurologist, and I work in the high-risk newborn follow-up clinic here at Mayo Clinic, which is a multidisciplinary clinic where we follow babies longitudinally to get a sense of their development. I also practice general child neurology and sleep medicine.
Thank you very much, you guys, for coming today to talk about a topic that I think is very important. The first, we're going to go over a number of different things today, but I think the first thing we should start with is just a basic definition of what spina bifida is.
Sure.
And because there is some confusion sometimes about what spina bifida means. And in general, as medical professionals, we tend to think of spina bifida as an abnormality called a myelomeningocele, which is a mouthful word, but basically means that the spinal cord, the babies are born with the spinal cord exposed on the back. You can actually see the spinal cord on the back and there's skin around it. But there are also other abnormalities that sometimes get confused or called spina bifida, where the abnormalities are with the spinal cord, but they're underneath the skin, and you can't see them visibly on the back. And there's a wide variety and spectrum of those. And we're going to focus primarily today talking about open spina bifida, where the spinal cord is visible at birth on the back, and usually very visible ultra with prenatal ultrasound. Yes. and prenatal MRI.
So nowadays we can make the diagnosis in prenatal care.
Yeah, that's right. And tell us more about that, Rodrigo. When do we make that diagnosis typically?
Usually we do we perform an anatomy scan around 20 weeks of gestation, and then we will be able to to evaluate the entire spina and the skin of the baby, and then we can identify a small sac on the back, and then this is the spina bifida.
Yeah. And one of the common questions is when we see patients together prenatally, when they have the new diagnosis, is what could I have done to prevent spina bifida from happening?
That's a very good question. So prevention of spina bifida starts for all patients, for all pregnant women. We recommend 0.4 milligrams of folic acid. The ideal situation would be to start before the patients get pregnant. But we keep doing the first trimester to prevent spina bifida. If the patient has a baby now with spina bifida, there's an increased risk for the future pregnancy to have spina bifida again. So then we can start the folic acid with a little bit more increased dose of folic acid to prevent spina bifida. Yeah. Do you agree with that?
No, yeah, I like your point, Rodrigo, and I think that the key issue is that spina bifida defect develops very, very early in embryonic life, by embryonic day 28. That is often much before the mother actually realizes that she is pregnant. So as Rodrigo, you pointed out, it's important to have a planned pregnancy and start using folic acid well before actually conceiving the baby. That is the best way to prevent.
So it's essentially all women that have the capability of becoming pregnant should be taking folate supplementation. Perfect. And that dose is 0.4 milligrams per day. And it's generally available in any multivitamin
Yes.
correct, for
Yes.
all women.
Yes.
Right?
Sure.
Yes.
So that's a very important point. You generally don't know whether or not the baby's going to have spina bifida until very late in the pregnancy,
20
later,
20
20
weeks.
weeks. You won't know that you're pregnant until the spinal cord has essentially been developed already.
Correct.
So the abnormality of spina bifida, as Dr. Kotagal mentioned, is all complete by 1 month.
Yes.
And you don't know that you're not going to miss your next menstrual period until that next month is up. So
Sure.
that all has happened, and so for that
Very
reason, we
good.
recommend all women that can get pregnant
Yes.
should be on folate
Folate
supplementation.
Excellent.
Perfect.
That's great. And what are the major findings in spina bifida outside of the abnormal spinal cord on the back, and what are the consequences of that? And I can, Dr. Kotagal and I can talk a little bit about the neurologic findings. One of the biggest ones is the finding called hydrocephalus, which is an abnormal amount of fluid inside the brain. There are cavities within the brain that make and hold cerebral spinal fluid, which bathes the brain, removes some of the waste products of the brain, and that fluid either gets trapped inside the brain as a result in part of a abnormality called a Chiari malformation, but it also has failure of the ability to absorb in addition to that in some cases. And the reason for that is because during the length of the pregnancy, the fluid is leaking out of the back.
Yes.
Where the spinal cord is exposed, the fluid that's normally produced by the brain is leaking out of the back. So the brain, the best understanding we have is that it doesn't develop the normal ability to absorb that fluid, on top of it being partially trapped. And that is an abnormality that's very, very common. It's 80% of babies that are born with spina bifida have that abnormality.
The Chiari malformation is.
They have a Chiari malformation almost universally.
The Chiari means that the posterior part of the brain comes down. Is that right?
That's right. It's the back part of the brain, the cerebellum and the brainstem they descend. They move down because the brain sags, because there's not fluid supporting it, into the upper part of the cervical spine. And it gets sort of pushed in there. And then as a result of that, it traps the fourth ventricle outlet where the fluid comes out of the brain normally. And because of that, the fluid builds up inside the brain up on top, and they get hydrocephalus. Exactly.
And that's important because we are going to mention about fetal surgery that.
Yes,
that
we'll talk later
aims
about.
to improve
absolutely.
that situation.
And that's one of the main goals of that operation, of
Sure.
course.
No, I completely agree with you. And getting back to the spina bifida, the location of the spina bifida sac makes some difference in terms of. I mean, if we didn't have the wonderful fetal surgery that you and Nick are able to do, what is the baby likely to have? It could have weakness of the lower extremities or the legs, but the degree of weakness really depends upon the level. The lower the level of the spina bifida, the better the outcome.
That's right.
Yeah.
That's it, right. So the more functional spinal cord you have,
Yes.
meaning the longer the length or the more levels that there are that are
Sure.
intact,
Yeah.
the better the neurologic outcomes. So
Sure.
we generally number those lumbar levels. Lumbar levels are the lower part of the spine. And the lower the level, like down towards the bottom of the spine, those babies generally have better neurologic function than
L4, L5.
L4, L5, or
Yep.
lumbrosacral, we say, lumbrosacral region, spina bifida, versus those that have a lesion or an opening of their spinal cord up higher on the back, like in the thoracic or high lumbar areas. Those babies are generally not able to walk and are wheelchair confined, for instance. Whereas those that have lower level ones generally have the ability to walk, sometimes with some assistive braces and other things, but generally can walk. So there's a difference in what the function is as far as your level of strength in the legs based on the level. And there's a somewhat weak correlation actually between what we find on ultrasound and what we see in anatomy versus what we see functionally when the baby's born, what muscle groups work. It's not a super tight correlation.
Yeah, what you're saying, Dr. Wetjen, is very important. So on ultrasound, usually we see the anatomic level. That means where the spine is open.
Right.
But what we are doing now, we are trying to understand better the functional level, even prenatally, on ultrasound based on the fetal leg movements, the movements of the leg movements of the baby.
And I suspect that's because the quality of our ultrasound has gotten so
it's getting
much better.
And then we follow exactly your postnatal exam that you do afterwards. So we
Right.
follow the same principles that you're saying here.
Yeah, so what we're looking for is, do they have the ability
To flex the
flex
hip.
their hips, then bring their legs up? Do they have the ability to move at the level of the knee? Can they extend their leg and bend their leg?
Perfect.
And it's harder to tell, but can they move their ankles or not?
Can you imagine we can do this on ultrasound prenatally?
And that would be terrific. That would be really terrific, because as it is right now, we have to really wait until the babies are born to give a functional level, which should be much more helpful to kind of anticipate what the needs are going to be if we were able to know that beforehand. That's really an excellent point, and it really it ties into this whole idea of what is the prognosis of kids,
Spina bifida.
babies that have and are born with spina bifida. What is the natural history? What is the course of their life like? And it really depends, as Dr. Kotagal said, on what the level of the lesion is. It also depends to a great degree if they have hydrocephalus or not. Those are the two biggest predictors of what their neurologic function is going to be.
Yeah, perfect.
Most babies survive.
Yep.
Most of them, greater than 90% now, in medical studies, probably more than this, are live to be 20 or older.
Mm-hmm.
And that's because of all the advances that have been made over the last 30, 40 years in the management of spina bifida. As far as bowel and bladder function, those are other things that we're looking at. We're also looking at their ability of their kidneys to function, their ability, if they're going to develop club feet, because the weakness in their muscles of their feet, and also things like scoliosis. And this brings in into this other idea of it is in general best if babies that have spina bifida are seen in a multidisciplinary spina bifida clinic.
Yes.
And
That starts even prenatally.
it does. These days, we have, at least at Mayo, our fetal surgery team is together and combined within the spina bifida care team. And Dr. Ruano is part of that. Dr. Kotagal is part of that as pediatric neurologist, are part of the spina bifida team. But also not only neurosurgeons, but we also have orthopedic surgeons, we have urologists, we have physiatrists, those are the physical medicine and rehabilitation doctors, physical therapists, occupational therapists. All these people come together in one location and see the patients over the span over 1, sometimes 2 days, get all the tests they need, and those tests might vary really depending on the age of the patient and how they're doing. But we all come together, talk about the patients, and decide what the best course of action is.
Yeah.
And one thing that I want to emphasize too is that it's not necessarily that you're going to have all of your healthcare needs taken care of in the spina bifida clinic. It's really the spina bifida part of it that's going to be managed. And we want to coordinate with the pediatricians that are out in the community where these patients are living so that we can best take care of them.
Sure.
Wouldn't you agree?
Absolutely. As you're talking, I can't help but think about the single operating principle we have at Mayo Clinic, which is the needs of the patient come first. So what happens in the spina bifida clinic is that the patient stays in a certain room, and all of us providers and our colleagues, we all come together, see the patient, and then we discuss amongst us to provide a multidisciplinary experience and feedback to the family and the patient.
That's right. And part of that need is that we want to make sure that their physicians at home are comfortable managing most of the healthcare needs of the child, because they're not excluded from all the regular childhood illnesses like everybody else.
Sure.
It's just those particular abnormalities that relate to their spina bifida that we look after.
Yeah, I mean, I don't know everything about child neurology. I don't know. I know very little sometimes about neurosurgery or fetal surgery. But working with my colleagues, I learn, and I think we all learn from each other, and that's what makes us able to provide a very high level of care.
And this is the
for
beauty
patients and
of
families.
multidisciplinary approach.
I learn every day from the colleagues I work with
Yeah.
in the not only the Spina Bifida clinic, but in all the multidisciplinary clinics we have here at Mayo. And Spina Bifida is one of the strongest ones we do have. There are now currently over 350 patients that have Spina Bifida that we see there on a year-to-year basis. We talked a little bit about hydrocephalus. We talked about the Chiari malformation as some of the other significant abnormalities we see. Another common disorder that comes about usually later in the childhood's life with respect to spina bifida is the idea of a tethered cord.
Yes.
And a tethered cord is a commonly confused diagnosis as well. It is a functional diagnosis, meaning that a patient has a certain level of function and then they lose that function, and that's seen in association oftentimes with an abnormality on imaging, but it cannot be diagnosed on imaging alone. And it's not uncommon to see an MRI scan interpreted as tethered cord when you really can't say that. All you can say from the MRI is what the location is of the abnormalities, that there appears to be some connection between where the spinal cord has been repaired and the scar where it's been repaired, but you really can't say anything about function because all the radiologist is seeing is the image, and they have to see those. You have to see those two things together to be able to make that
So
diagnosis.
tethered cord is when the cord seems to be attached to the skin,
it's right in the region of where you do the repair for the spina bifida. There's scar that develops,
Okay.
and sometimes that
and then
scar
it stays fixed there.
fixes the cord. And then if that's strong enough fixation, as the baby grows, it stretches the bottom part of the cord, and then they can lose function that they previously had. And it's usually progressive weakness, progressive pain in the back, sometimes down the legs, or progressive sensory loss. And sometimes if they had prior bowel and bladder control, that's not often the case in spina bifida babies, but if they had that and they lose that, that may also be an indication that they have a tethered cord.
It may happen because the cord in children is child is a little bit lower than in adult, or
a little bit, but not significantly. There used to be thought that there was quite a bit lower. It is prenatally to birth.
Is lower.
It's definitely lower from when you make the diagnosis on ultrasound, and then where it ends up being at childbirth by a level or two. But it really doesn't change very much after birth. It usually is at the higher lumbar levels and stays there. In spina bifida, it is lower.
it is because
It's definitely lower by definition.
because
It's
of the
down at
problem
bottom,
there.
because of the nature of the congenital anomaly. And if it scars down there, and because the spinal cord doesn't grow as fast as the bones and ligaments and everything else in the spine, it stretches out the cord. And if that happens, then we need to be untethering the cord, where we basically go in, we use monitoring.
So you open it.
We open up the level above where the scar is, identify normal anatomy, and then work our way towards the abnormal anatomy and dissect the scar off the cord, taking extra care not to hurt the spinal cord
So do
itself.
you use microscope? to
We
see
use
that?
a microscope, and we
And
also
usually
use
even
monitoring.
prenatally, huh?
Well, when we do prenatal repairs, of course, we use a microscope. But for the tethered cord, we use a microscope and we use monitoring. We have EMG, and we can also use spinal cord monitoring, which are called somatosensory evoked potentials or motor evoked potentials. Generally, though, EMG is enough for me to be able to do the surgery safely.
Perfect.
Yeah.
So before you both get into the wonderful fetal surgery that yours skill
He's
and
anxious to
expertise,
discuss that.
I want to talk about the sleep issues that
Yes,
end up
please.
happening, and lots of times the spina bifida children, as they get older, they don't move their rib cages very well, so the chest expansion is not great, and also as Nick, as you mentioned, they have Chiari malformation of the brainstem, so the brainstem, lower part of the brain, doesn't regulate the signals for breathing very well, so they are at risk for sleep disordered breathing, or that means having trouble with apnea or stoppage of breathing while they are asleep, or having hypoventilation, which is just shallow breathing during sleep, as a result of which they cannot blow off their carbon dioxide, they drop their oxygen levels, they are tired in the daytime. So it's a good idea to get at least what we call a screening oximetry, just a measurement overnight of their oxygen saturations during sleep, and if the oxygen levels are abnormally low, below, that means below 90%, consider referral to a sleep center so that we can evaluate their sleep sort of breathing in more detail and help them out with, say, use of positive airway pressure breathing devices.
So that's generally the treatment for that, Suresh,
Yes,
is a positive airway pressure
yes,
breathing
yes,
device.
and it really helps to open up the alveoli, fill the lungs with air, and keep the upper airway open, and it does seem to help.
Yeah, and probably significantly improves their quality of life if they're more rested during
Sure.
the day.
Yes, they're more alert and able to function much better.
Another good reason to have a pediatric neurologist as part of our spina bifida
Of
clinic.
course.
Thank you.
That's
Dr.
really great.
Wetjen, I have a question for you.
Yes.
Since I'm a fetal interventionist and
Sure.
an OBGYN,
Yeah.
so what age does the tethering happen in a child, for example?
That's a good question. We generally see the symptoms most commonly when the kids are going through growth spurts. So, but it can happen really at any age. It can happen as soon as several months after we've done the
Delivery?
initial repair. That's relatively uncommon. I would say the majority of the kids that I have operated on and taken care of for tethered cord syndrome generally are early school age, preschool age, and then occasionally then again in their teenage years. And the lifetime risk of that's about 20 to 25% of babies that have spina bifida and have a repair will at some point in their life have a spinal cord that's tethered.
So how would you follow those children with spina bifida?
Excellent.
This is very
That's
important.
the whole point of the
because
spina
then
bifida
you can diagnose this very early.
Well, in my view, one of the major points of the spina bifida clinic
Sure.
is that you have a consistent person over time do neurologic exams so that you can detect a change. Sometimes it's relatively subtle to maybe hint towards maybe they do have a tethered cord now.
It's perfect. So
Yeah.
that's the importance of the
Yeah.
multidisciplinary
Manual
spina
muscle
bifida
testing, we call
clinic.
it, and the physical therapist, generally it's the same physical therapist each time, but it's a small group, so they know the patients quite well.
Perfect.
And they can say, yeah, I'm not really sure I remember them being weak in this muscle group
Surely.
the last time they were here, and if that's the case, well, let's take a look, let's get an MRI scan and refer to neurosurgeon.
Sure.
Perfect.
And with our electronic medical record, we can go back to look at our own notes from a few months ago or a year ago.
All the way back to the beginning
exactly
of time.
why, yes.
And we are going to start soon to get medical records from the fetal, for the prenatal
right?
records. So the
Okay.
children will have, the child will have prenatal medical records.
Is that right?
That will come.
Well, that'll be cool.
Well, that'll be wonderful.
Yeah,
That's
then we can
great
see
news indeed.
functionally what they're like. Because right
Prenatal,
now,
yeah.
it's hard for me, I don't see that on an ultrasound report, for instance, what their functional level is. But if that's
Yeah.
the case, then
That's
that
very
would be
new.
very
That's right.
interesting to see how that correlates then with what they are at in the newborn nursery.
Yeah.
Yeah,
That'll be wonderful.
that's great. We talked about hydrocephalus, we talked about tethered cord. Other abnormalities of neurologic function are seizures. It's not super common, and and certainly not all kids with spina
Sure.
bifida have that,
Sure.
but about 20 to 25% do.
Sure. Yes. So, as you very early in this discussion, you pointed out that the distension of the central canal or the spinal cord may not happen with this leakage of fluid before the baby is born. That really, if there's leakage of fluid and there is not sufficient pressure building up in certain parts of the brain, of the embryonic brain, then the development of nerve cells and supporting cells and their migration to the appropriate regions of the cerebral cortex, the outer parts of the brain, doesn't happen. So we can have a situation where the nerve cells get stuck in abnormal locations. If they are abnormally located, they develop abnormal cell-to-cell connections, and that's what makes them more prone to increased excitability and have events like seizures, which of course seizures means a burst of abnormal electrical activity, which leads to alteration in consciousness or abnormal motor function, twitching, jerking, etc. But seizures are something that are treatable with appropriate medication.
Right, and most of the spina bifida associated seizures are treated primarily with medications. I
Yes.
can't recall a patient that I've ever had
Yes.
medically refractory
Sure.
epilepsy with. I'm sure that it happens, but
Yes,
it's relatively uncommon
Sure.
that we wouldn't need to do surgery for it. And I think that kind of wraps up kind of the neurologic things I wanted to talk about
Sure,
with
sure.
respect to spina bifida. And we invited Dr. Rodrigo here to talk about one big thing, which is fetal surgery. And Dr. Ruano joins us now since October, isn't it?
October,
From Houston, now here at Mayo Clinic, and he and I together do the repair of spina bifida in utero before the baby is born in the pregnant mother. And I'll have you kind of talk about who's a good candidate for that, what the benefits of having that surgery are, and I can help,
Perfect.
we can talk together about some of the neurologic
So
things.
it's a pleasure to work with you on this big program, which is, as we discussed, fetal surgery is a multidisciplinary program. So as you can see here, we have different specialties working together.
Yeah.
The main object of the fetal surgery for spina bifida, which is different from other types of fetal surgeries, is that this is not a life-threatening situation as you spoke before.
right.
So we are not treating the baby in utero to try to prevent death.
Right.
We are trying to do that to prevent neurological complications as discussed here. So why? Because we believe that there are two steps in the physiopathology of the disease. The first one is whenever the disease started, as Dr. Kotagal mentioned, about early in pregnancy, we have already the nerves, some neurological problems.
In life, timing is everything.
Yes. But the second point is that we believe that since it's an open disease, the fluid is leaking from the brain through the spine and causing the brain to come down, as you spoke before. And secondly, we believe that the amniotic fluid in contact with the nerves can cause some inflammatory reaction. So our objective with the fetal surgery is try to close the defect in utero to try to prevent or to stop the progression of the disease. And then so far there is a very good study, randomized control trial that took about 7-10 years to be concluded. Multi-center study that they compared babies who underwent the fetal surgery versus those postnatal repair, and then there's some benefits to the baby. One is that we can stop that process when we close in utero together. Then we can reverse the Chiari malformation,
Right.
which we reverse in about 80% of the time, versus less than 30%.
Yeah.
So we improve that. So we reverse in about 80% of the time, and also we decrease the chance of hydrocephalus, which is fluid in the brain that then you need shunts and further problems.
Yeah, and that
Then
was the primary purpose of the study, was to show that it reduces the risk of hydrocephalus, and it does. And in that group of patients with the randomized trial, where 80% of the babies that were repaired after birth developed hydrocephalus, only 40% of babies that had a prenatal or fetal repair developed hydrocephalus. So when you think about, when you have a treatment for hydrocephalus that involves a neurosurgical procedure, either a shunt, and in some cases now endoscopic procedures, those shunts don't work all the time. They have a high rate of failure. About half of them fail within the first 2 years of life, and they can fail at a rate of 5 to 10% per year throughout the baby and child and adult lifetime. So that can lead to a lot of operations over the course of a lifetime in some patients, and certainly not all of them. But if we can reduce the risk of hydrocephalus from 80% to 40%, number one, it reduces the risk of hydrocephalus in general, but we're also reducing the risk of future surgical procedures and hospital costs and infections and overall quality of life. So it really has a profound impact, I think, to look at that as a primary endpoint. And as you mentioned too, the babies do better motor-wise.
Yes.
They're twice as likely to be able to walk independently. Certainly not all the kids that we operate on for fetal surgery are able to walk independently, but in the study, twice the number were able to
walk.
Yeah, it went to 20% to 40% roughly that are able to walk independently.
And we usually offer this type of surgery from 22 to 26 weeks.
Yeah.
The patients, they come for complete evaluation, 1 2 days of evaluation, and then the patients see all the different specialties, ultrasound, MRI. We discuss together, but the main inclusion, the condition, the candidates for this type of surgery, the main situation is spina bifida, usually lumbosacral defect. Problem related to the Chiari malformation. So once we confirm that there is a Chiari malformation, then of course we carefully evaluate the mother's situation and then a condition to see if there is no contraindication for the procedure. So that's why this evaluation is very important.
What are the most common contraindications on the part of the mother for having fetal surgery?
Well, nowadays we are working to change that because, but one of them is obesity. So if the obesity is something, because this is a big surgery, so that we need medication to stop the contractions. We open the uterus. So this surgery, we open the uterus. We expose the baby's back, and then Dr. Wetjen comes, and then he closes the baby's back, and then we close the uterus, we close the maternal.
So it's mostly a technical problem, really.
It is.
And maybe risk higher for being
preterm delivery.
Delivery.
For example, the patient has like some problems in the uterus, but we can discuss it. There is some list of events.
And it's important because obesity is also an independent risk factor for spina bifida.
And that's why we are going to move to the next step. The next step is to see if we can do this repair under fetoscopic, just putting scopes inside, and we can be less aggressive for the mother, but we can even allow the patient in the future to have vaginal deliveries, for example, with the same success that we want for the baby.
Yeah, so now we have to open the abdomen of the mom.
Yeah.
To do it open, bring the uterus out, open up the uterus, and then expose the baby's back, and then using a microscope, I do the repair.
Yes.
But in the future, we're moving towards, and it's actually been done. It's not futuristic per se. Dr. Ruano has done it previously. We just haven't started doing it here at Mayo Clinic yet. Is to do it fetoscopically with an endoscope.
Yes.
Or fetoscope, and there we open the abdomen, but we don't open the uterus.
Yes.
We just make openings of ports, right?
Yes, and then we can achieve the same goals for the baby, but being less aggressive to the mother. We already doing this with the incision. We are doing less smaller incisions in the uterus.
No question.
To be a little bit less aggressive with the mother.
Yeah.
And then of course we follow the patients once a week here, weekly, and then we deliver here, and then we take
From
care
my
of
perspective, doing the repair, that's the biggest challenge. Is getting that back, the spina bifida defect right in that opening. To be able to get the repair in through the smallest incision we need to do the adequate repair and being able to do it effectively without damaging the baby or the uterus, right? That's the real technical challenge of it. And then in doing microsurgery and a breathing, moving.
Yes, it's definitely is not an easy procedure. It's as you said, we need to have experience, and then but multidisciplinary approach and this combination of approach is very important.
I think one of the big benefits of having you here now, Rodrigo, is that prior to we did one of these maybe almost once or twice a year, where now we're almost averaging one a month. So it's really increased. We're getting more experience. We're doing a lot more, and it's obviously the more
and
you
the
do,
patients
the more
are doing
comfortable,
fine
and
too.
the patients are doing great.
So how can providers and patients seek help from your team?
They can contact us at maternal fetal medicine, obstetrician and gynecology service, looking for
I think at the conclusion here today, too, there will be contact information where they can make an appointment.
Sure.
Yeah.
That makes sense.
You can just call the General Mayo Clinic appointment office and ask to be transferred to fetal surgery team, spina bifida team, neurosurgery. Any one of us, we would be able to get you in the right place.
And then we can talk about other types of fetal surgery for
Yes,
another day,
yes.
maybe, because today is going to be, maybe it can be a long day for us. Huh? But I can talk
So
quickly
yeah,
about that.
what other types of fetal surgery are we doing besides spina
We
bifida?
are nowadays at Mayo Clinic. We are offering all types of different surgeries that we can do. For example, we can do a fetoscopic. We can put a scope inside the amniotic cavity, and we can for twins, and we can separate the placenta for a situation called twin-to-twin transfusion syndrome. So when we have identical twins with one placenta, the vessels are together, so we can close those anastomoses and we can separate the baby.
Yeah.
So
The
blood
function.
supply from one fetus is going into the
The
other.
other one. And so
And the other
then-
one ends up being bigger, and the other one ends up being very
Yes.
small.
and
Yeah.
then we can lose the entire pregnancy in more than 80-90% of the time without surgery. And if we try to, and if you stop those anastomoses, then we
sure.
can have
Two
80%
twins.
chance of
Yeah.
having both
Well, that's
babies.
terrific.
So this is something that we can offer, and also we start a program of tracheal occlusion that we can put a small balloon inside the baby's trachea or airway inside the uterus for lung problems like congenital diaphragmatic defect, a hernia. So whenever the fetus has a congenital diaphragmatic hernia, there's a hole in the diaphragm, and then the bowels come up and blocks the develop of the lungs
Yeah.
block the develop of the lungs.
So that for the audience, the diaphragm is the major muscle that controls breathing.
Yes,
And
postnatally.
it's usually, it can be defective on one side, and if it's defective, the bowels, as you were saying, go up into the chest cavity, and you can prevent that from happening
Yeah,
with the fetal surgery.
Yeah, so we can because as a consequence, the lungs will be smaller than normal. These babies can die. So what we at around 28 weeks, we can put a balloon inside. We can puncture the belly. We can puncture the uterus, and just with a tiny scope, 1 millimeter, 2 millimeter scope, we can place a balloon inside the trachea that can make the lungs bigger. So this that we call tracheal occlusion. We can also try to open an obstruction inside the baby's bladder,
Yes.
put in a scope, which we call posterior valves, and we can speak about that. But whenever we have an obstruction in the bladder, there's no fluid around the baby anymore because the baby's
Doesn't
urine,
make urine.
yeah, is responsible for the amniotic fluid. And then if there is no amniotic fluid, the lungs, they don't develop, and then also the urine inside the bladder can come back to the kidneys, can cause problems. So these babies will die because of lung problems or kidney problems.
Yeah.
So there's a way that we can put a very tiny scope inside the bladder. We can see the obstruction, and we can open the obstruction, and then we can restore, we can repair, we can have more fluid around the baby, and we can improve the lungs. Okay. So those are some of the surgeries that we can do.
There's just a few. I mean, all of these are new since I was in medical school, so it's really fascinating what the capabilities of fetal surgery have changed, how much they've changed the care of newborns since I've been even in training. So it's been really incredible.
Sure.
Do we have any questions from the audience so far? No, so far we don't have any takers. No questions. So that's all we have time for today. Thank you, Dr. Ruano, and thank you, Dr. Kotagal, for joining me today to talk about spina bifida and fetal surgery. This discussion will be on Mayo Clinic's YouTube channel for future viewing if you didn't have a chance to see it live. And if we didn't get a chance to answer your question, or you have some that come up, we're happy to answer those if you put them on the YouTube channel or on the Facebook site. And thank you very much for joining us today, and have a great day.